Welcome back to another episode of 22 at the Lips. I am your podcast host, Alexis Hardwick. And today, let me start over. I'm so sorry.
These
Oh,
are bloopers.
okay.
We can put them in at the tail end of the show.
Welcome back to another episode of 22 at the Lips. I'm your podcast host. And if you are new to the show, if you just stumbled upon who we are, what we stand for, great question. But this is the EMS provider podcast to EMS providers, healthcare providers, whether you're pre-hospital, in the hospital, or at a family clinic, wherever you may be. This is the podcast where we talk about things related to EMS, whether it's education, we just have little sit down chats, specific topics, whatever it may be. Just a little slight note if anybody has noticed a little hiatus, I guess we'll call it. My husband and I just moved to Mount Pleasant, Michigan, which is quite literally across the United States from where we were in Louisiana. So, a little bit of construction behind the scenes, quite literally, if you're seeing this on video. The wall is baby blue for now. Definitely not my style, but we're just going with it for now. But besides all of that, if you've been keeping up with the podcast, it's been a hot minute, but now we can call him Dr. Matt Gehm. He is back on the podcast, back to give us enlightening information, and now especially information that is above my pay grade. So, Matt, if you want to reintroduce yourself, give us the updates. Where are you at now? The floor is yours.
Thank you for the kind words. I don't know if this information is above your pay grade by any means, but I appreciate you hyping me up a little bit. For those who aren't familiar with me, I suppose my name's Matt. I'm an emergency medicine physician resident in upstate New York. Recently graduated medical school. I've been in EMS for a little bit. Did ground 911 transports, did some critical care stuff, and now someone decided it was appropriate to let me be a physician. So it's been a lot of fun so far, and I think today's podcast will have some good topics.
Absolutely. So Matt actually, or Dr. Gehm, I'm sorry. He was the one that brought up the topic first, and I love it. I love all things that are pretty, I mean, I don't want to say ambiguous, but kind of blur the fine line of, going from paramedic school, EMT school, where you have your cut and dry scenarios. Your patient, when you walk in, automatically has chest pain and left arm pain. Branching out from that idea, we are going to talk about the dizzy patient. What does that mean? What does that even entail? What does that look like for us? Something I kind of want to hit on with this topic is the idea of, there's no protocol for your dizzy patient. There's no, is, I want to hit on like, is this a BLS symptom or can it be ALS? Where do we fall in the realm of that? So, Matt, if you want to start off, what does it mean when a patient tells you their chief complaint? Maybe you find out 5 minutes from the ER that they say they are dizzy. What does that mean?
Yeah, I think this is one of those very interesting complaints in emergency medicine and even in primary care. We see this everywhere. And you're exactly right. It's one of those ambiguous ones where it's not like you can necessarily just open up a textbook chapter and find one labeled dizziness. I think it's a very broad term that even from patient to patient can be described differently. And I think that makes it very diagnostically frustrating for us because we're trying to figure out what's going on. And well, I'm dizzy. Well, what does dizzy mean to you? And so many people will describe it differently, even over the course of the same interaction. And there can be some very serious consequences to not getting to the correct diagnosis for these patients. There are some very malignant things that cause dizziness. So we want to make sure that we're correctly stratifying these patients into who are high risk candidates who need the full workup, need to get CTs and seen by neurology or other specialties, to maybe the patients who are lower risk and just need some reassurance. So dizziness can be a fascinating field to really get down into. And I think at its core, we have to discern what symptoms they are actually feeling when they're saying dizziness. I think if you ask one person, dizziness is being lightheaded. They feel like they're going to pass out. So, are these actually patients who are having a pre-syncopal event? Or maybe they had a full-blown syncopal event and they're just waking up from it and they're still feeling lightheaded and they're saying that is their dizziness. Or these patients that are having more vertiginous symptoms where they're more vertigo in nature and they might actually be feeling motion or the classic description of the room spinning and they're actually having an inner ear problem. So I think these patients, a lot of the workup is really based off of history, with a few key physical exam findings and a very high suspicion for badness. That's how I approach dizziness, and I think it's a good starting basis is to really narrow down what exactly is that feeling that they're having.
I always go to as soon as a patient says they feel dizzy, I don't know why. I guess it's past experience. I always like a knee jerk reaction in the back of my head. It's, oh, they're nauseous. I don't know why. I don't know if it's because typically that comes with that dizziness. My immediate is, oh, they're about to throw up. And I think that's just like a defense mechanism because anytime I've had a patient that says they feel dizzy, at some point they end up throwing up. And there, like you said, it's a myriad of definitions. I specifically put near syncable just because in my experience, in my mind, it's the room is spinning and slash or I feel like I'm about to pass out. I feel dizzy. I feel lightheaded, um, lethargic, again, nauseous. And I like that you highlighted the importance of like a good history and a good assessment because if you fail to ask the questions of is this acute or have you dealt with this for the past year and you're calling and you're going to the hospital again for the same thing, it makes a big difference. And also in that asking for pre-existing medical conditions. Had a patient one time that she called because she's dizzy. Turns out she's had vertigo her whole life, and you can kind of go down that treatment route. Uh, Caveat in that, but we'll get to that in a second. And even as far as asking like your sample OPQRST, ABCDE, whatever other acronyms we have out there, asking that, and I think it's very important to ask for the provocation, palliation, what makes it better and what makes it worse? Because that can cue you into if you're going down the road of dehydration. Okay, when I stand up, it's worse. Or could it be cardiac? Because when you stand up, it's worse. Or this, that, and the other. And kind of where it really plays into the routes we take as far as not just protocols, but like thinking in the back of your mind what you're going to have to do. It helps differentiate between when you take into account dizziness. Is it new? Is it old? Medical history? Do you have a history of hypertension? Oh, okay, no wonder your blood pressure is sky high and you feel dizzy. It can help you lead to a route of, okay, should we assess for a STEMI? Should we, I think this one's very important, assess for a stroke? If we're going to have to pace, cardio, or whatever it may be, or it can be a peri-arrest symptom, which is terrifying. Um, so, what would you say if a patient says that, like, my chief complaint is dizzy? Where, and this is kind of a hard question, where are you going with that? Besides like asking history, besides asking, what is the things you want done the most important first? I, I don't know how to phrase that question. I'm so sorry.
Yeah, I mean, I think the key thing is whenever you're getting dispatched and the chief complaint is coming in as someone who's dizzy, or if I'm seeing on our track board the chief complaint is dizziness, I kind of try to already separate out my buckets of patients of categories for me. So, I have my big broad categories of this is vertigo symptoms, dizziness, and then I have my list of causes. And you can split that into central causes where you're thinking more brainstem, stroke, tumors, masses, things along those lines, and then peripheral causes, which are more ear problems. So things like Meniere's disease, benign paroxysmal positional vertigo,
Wow.
labyrinthitis, ear infections, all these other ear problems. And then another peripheral category that I think a lot of people disquate and don't necessarily consider are all of our neuropathy patients. So, vertigo in dizziness patients, in the sense of balance, is actually a really complex process. It involves vision, ears, your central brain, and then your peripheral nerves. If any one of those goes out, people can feel dizzy. So, every single one of those categories has its own myriad of conditions. So, diabetics who have diabetic peripheral neuropathy can often get dizzy because they simply can't feel where their muscles and extremities are in space. So don't discredit that as a possible cause for this. Then once we get out of the vertigo symptoms, and maybe they're actually describing things more along the lines of being lightheaded and pre-syncope. Well, then I start going down cardiac issues. Do they have an arrhythmia? Do they have a heart problem? Or do they have heart failure? Are they a high risk for having something to cause them to feel lightheaded from a cardiac standpoint? Are they vasovagal? Are they orthostatic? Are they dehydrated? And then the other big category for me, especially with our elderly patients, are medication side effects. Some of these patients are on so many different blood pressure medications. Sometimes their dosages get increased. Sometimes they might get a little dehydrated and their kidneys don't clear medications quite as well. So they build up and they get more side effects. During the flu and cold season, people are using a lot more antihistamines and Benadryl. That can certainly cause you to be dizzy. So medication side effects is my other big category. So those are kind of the things that I initially split things up to before I even walk into the room. That these are the things that I'm thinking about. These are the questions that I want to ask the patient to try to help me determine where I'm going in this direction. And then from there, it's just all history. I would say that I get probably close to 70% of the diagnosis for dizziness based off of history alone. And then probably the next 20% to get me to 90% of the way there is off physical exam. And then the remaining 10% is labs and imaging, more or less just to confirm what I think is going on at that point.
When you say the physical assessment part, what I mean, we have like our classic, we're doing our head to toe, whatever, but what outside of that realm kind of cues you into different aspects of where you're going with your differential, all that stuff?
Yeah. And, I think that's an excellent question because I think as we get more and more into things like imaging and ultrasounds and blood work and stuff as it moves into EMS, I have a worry that we're going to get farther and farther away from a physical exam, which I think is a disservice. So, listeners out there, please do physical exams; that they are well worth your while. Um, and, first, just looking at the patient. If I have a patient that is saying they're dizzy and their skin is pale and they are diaphoretic, those are
Oh,
immediate red flags. Those
oh
are
no.
patients who are high risk for all sorts of badness. So that would be the first thing is just looking at the patient. Often, if they're sitting perfectly still and they're not moving, that's another thing that I should pay attention to, right? They're not moving because they're so dizzy that they're thinking something bad's going to happen. So if they're sitting perfectly straight and not doing anything, well,
Oh
why aren't
no.
they? A typical person isn't going to do that. And then getting a little bit closer to where now we're actually starting to do a physical exam and we're feeling things and we're, trying to see what's going on. I really like to look at the eyes. I think eyes are an underrated role in terms of dizziness. So what I'm looking for is nystagmus. Um, and nystagmus, when we're having people and checking their eye movements and looking left and right and up and down, if we can see nystagmus, that really points you in a direction of what type of vertigo this could be. So these patients are describing motion, they're describing room spinning. It's acute in onset, it's very positional when they change their head. I want to see what their eyes are doing next. Um, and there are great videos out there of this that you can actually see the different types of nystagmus. And I would encourage you and listeners to look at some of these videos. But in short, anything that is up and down nystagmus is bad. That is a central cause of dizziness. That is a stroke until proven otherwise. That is a bad sign. Anything that is rotational with the eye spinning a little bit or the this iris spinning, it's called a torsional nystagmus, is also bad. That is another red flag. If you see one direction beating, that's a little bit less worrisome. That's usually more peripheral issue. But I would say the key things, if you see vertical nystagmus or twisting nystagmus, that should be considered a central cause and considered a stroke symptom until proven otherwise. I think those are the big initial physical exam findings. The last thing that I really try to do once I think it's safe for the patient and we've taken vitals and they look like they're doing okay, is I really try to have them walk. I feel like in this scenario, if a patient can walk and they're not incredibly unsteady, certainly they may still be feeling some symptoms, but generally, as a broad rule out there, if you can walk and you're not incredibly ataxic, you're not immediately falling over, that's a reasonably reassuring sign that this is more of a benign process. So having a patient walk, as long as it's safe for them to do so, I think is a very reasonable screening test for patients.
I've never thought about, like, I know the pupils are very important in your assessment, yes, but vertical nystagmus, I'm gonna be very honest, I've never heard of that, it sounds terrifying. That's
Yeah,
enough that I would be like, "Oh, no, baby, let's get in and let's go very fast."
Yeah, and it's definitely a red flag. Those are things that I think need to be taken seriously. And it's one of those things that is so simple to do. It takes 30 seconds to do, but it can really change the course of someone's outcome. So I would really encourage people to look up some videos about different types of nystagmus when dealing with these patients, because we're going to run into dizziness all the time in EMS. So it's a benign exam to do, and I think if you can find it, it'll raise your suspicion, and it's worth doing.
Yeah. Um, what would you say is, I mean, there are different aspects of pre-hospital care and treatment and stuff, but I think most of our job, what I'm coming to terms with is that, like, if it's not quite literally life-threatening, that's why we're called emergency medical services, um, much to the public's surprise sometimes. But if it's not a life-threatening issue in that moment, there's not really much we will be able to, can, or honestly should do. So, like with our dizzy patients, if it's not a STEMI, if it's not a stroke, if it's not hypotension secondary to sepsis or polypharmacy or whatever it may be, dehydration, all of the things we can run into, but it's, you know, Momo's had vertigo for the past 5 years. She's overworked herself, but it's coming out as vertigo. We did possibly a 12 lead. We did this, that, and the other. She just wants to go to the hospital. What are some aspects of patient care that we can provide? And I kind of want to caveat and kind of clarify of supportive care.
Yeah, I think if you have the right patient and, your physical exam is reassuring, they're walking, they've had a couple episodes where they're dizzy, vitals look okay, and, you have that history in the patient. Oh, I've had this vertigo in the past. Maybe I just ran out of my medication, or, it's presenting the same way it always does. I don't necessarily know as if there needs to be a lot of aggressive interventions. I certainly think to some degree a lot of those patients are relatively stable, and again, in the right setting, could very readily be supported with just supported care, and take a nice easy ride to the hospital. Certainly follow local protocols for what needs to be done. But I think a lot of it is just reassurance and just having that index of suspicion there of, is there anything that I'm missing, and is there a potential for something worse going on? And I don't necessarily mean that in a way that you have to, start bilateral 18s in these patients and, put defib pads on them and all that stuff. But I think depending on where you work, certainly when I was working on the ambulances, I had several hospitals that I could transport to, ranging from, smaller critical access hospitals that don't necessarily have a lot of services, all the way up to the tertiary care center. So I think that's where EMS can play a big role, is decision makings and advising patient on what hospital they should go to. Certainly for the right patient, maybe that local critical access hospital where they just need to have, a physical exam, maybe get a refill of some prescriptions and make sure nothing serious is going on, is appropriate. Um, but what I hope people gain from this podcast is the ability of the knowledge to say, hey, something doesn't seem right with this patient. Something on their physical exam feels off. Something is wrong. Maybe I shouldn't take them to this critical access hospital. Maybe I should take that extra 20 minutes to go to the stroke center or the cardiac center or whatever have you. just to try to not delay care if there is something going on. I think that would be a really big impact for a lot of patients.
And as a segue of that, it's hard whenever you're on your 5th call and you've only been on your shift for, like, 6 hours. You've been thrown to the elements of everything, and then you get this patient who calls because they're dizzy, or they call at 2 o'clock in the morning because they're dizzy. It's I mean, same with so many other symptoms a patient can have that's not blaring red flag in your face. It can be easy to kind of pass it up, but like you said, it's why we take the time, especially we show up at their house. You take the time to do your history taking. You take your time to do your physical assessment. You listen to your patient, and I mean, honestly, with every patient, the more you let them talk, the more that they just reveal about themselves. It's such a weird dynamic because we're meeting these people for the first time ever, and they're just spilling, hopefully, spilling their guts out about so much stuff. Sometimes it's too much, but listening to your patient, understanding what's acute, what's not, and also with the differentials in the back of your head of what could be going on, what's not ruled off the table, what to expect. Um, Especially again when it comes down to that line, depending on the agency you work in, is this a BLS call or is this ALS? And even in that caveat, things can change with, I don't know, a bump in the road, and all of a sudden things are terrible. Um, you've never had that experience, just wait, buckle up. Um, One thing I do kind of want to touch on, do you see this in what how do I put this? What age population is this more prevalent? Because I have an idea in the back of my head, not trying to be, what is the word, ageist, but like in the back of my head, I already know the age range of who we're going to and who I don't want to say pay a little more attention to, but kind of have my head on a not head on a swivel. I don't know, my senses are heightened just a little bit more versus other age populations. What's Is there like an age range of when you're apt to say this is a little more serious than others?
Yeah, no, absolutely there is. I think, this is a complaint that can appear in any age group. Um, and I think, my index of suspicion for badness and serious pathology increases as their age goes up. So, to me, an elderly patient that is, explaining dizziness to me for the first time and has otherwise never had it before, that's somebody who I'm reasonably concerned about that probably needs a very thorough workup to ensure that there is nothing going on. So my threshold to do things like EKGs, blood work, and imaging of that patient is pretty low. I think the odds of finding serious pathology in an elderly patient significantly increase. So certainly anybody who's over the age of 50 for me is somebody who I pay attention a little bit more to when they're complaining of these symptoms. I think your younger patients um, tend to be, healthier. They're less disease ridden. They don't have quite the vasculature diseases that your other uh, more elderly patients tend to have. I wouldn't necessarily say that they don't ever have serious pathology because they certainly do. But from a pure age standpoint, the older they get, the more concerned I am. For me, the younger patient that is, acutely dizzy, I tend to be more concerned for things like medication, substance use, um, dehydration, electrolyte abnormalities. And then in the right patient, multiple sclerosis can cause dizziness. So that's kind of another thing that I would consider if this continues to happen over and over again. And the right patient that maybe is just been having dizziness and nobody's been able to figure out if it's something that I can consider. But as far as like the more serious pathology, it's definitely somebody who's over the age of 50 for me is somebody who I start to consider a little bit more.
I think another key aspect to consider when you're doing your history taking and whatnot is asking how long did it last for? Is it still going on? Because I know me, myself, and I, if I stand up too fast, ooh, I feel a little dizzy, maybe
Hmm.
5 seconds, maybe 10 seconds. Um, I have a phobia of birds, so if I'm somewhere and there is a bird close by, my heart start racing and I get just a touch dizzy because I am petrified. So as far as like duration of time, would you say it's and this is kind of, I feel like it's setting it up for a no-brainer. Is it more serious the longer it goes on? Because then you also have to consider if this has been years and you don't have a diagnosis of vertigo, you may very well, congratulations today, it's a touch of the vertigo, friend. So, like, does duration have a huge consideration, or are you still going down the same pathway of thinking, whether it's, it's a dizziness that lasted 5 minutes and it's not come back, or I've been dizzy for the past 5 hours?
I certainly think to a degree that time plays a very big role in my history. I think like you were describing the orthostatic change very classically there, standing up, getting dizzy, it lasted a couple seconds, got better. I think that that's a relatively reassuring history, and a relatively reassuring time course. Um, I think other things in relation to timelines of what happened when it first started. Were you making like a sharp movement with your head? And that's when the dizziness came on, and then it lasted for a couple minutes and then got better. Then you moved your head again and the dizziness hit you again. In that scenario, that sounds much more inner ear to me. Um, and as a large and whole, if you're persistently feeling dizzy for longer than a few minutes at a time, that makes me a little bit less concerned for the benign paroxysmal vertigo. You might still have a peripheral ear problem like a labyrinthitis or some other more rare conditions that can cause inner ear issues. Um, but I think at that point, I start to consider, maybe this is more of a central cause and it needs to be worked up a little bit more. True vertiginous symptoms where people are describing the motion, the room spinning, they have issues with walking, things like that don't last incredibly long in terms of like weeks. The body can compensate pretty quickly for that. Your body will readapt and change around things. So at that point, if it's lasting weeks and it's truly constant, there's more of a consideration for a psychogenic component of the dizziness. But that's always a diagnosis of exclusion. We never want to just assume that this is a some sort of psychiatric disorder before we rule out other medical causes first. Um, but certainly, if it's going on for weeks and they're saying it's persistent dizziness all the time, it's a consideration. But I would definitely hammer down and really, really try to get out of the patient. Are you just having frequent episodes of dizziness that is going away and you're saying it's all the time? Or are you just having the symptom with no relief at all at any point? Because people can have relapsing vertigo from, benign paroxysmal versions that just keep coming back over and over and over again. And that's not the same thing as constant vertigo all the time.
I think that's a really good point. I'm gonna be so for real. I've never thought about asking, like, is it all the time, or is it reoccurring over time? That's a really good point. Um, okay. So when we encounter this patient in the pre-hospital field, um, we get there, we do all of the assessments, all the things. We do a 12 lead, a stroke assessment as much as we can. Because granted, we are fairly limited compared to the hospital setting, but that's okay. When you do all the things and say it's acute or it's not, kind of situation dependent, but the patient doesn't want to go, but you think they should go to get checked out. Granted, depending on your protocols, depending on this, that, and the other, if they're ANO4, GCS 15, not much we can do. But what can we kind of warn the patient about? Because that's what, with any refusal, secondary to, fender bender, I got 10 out of 10 back pain, and you can't even see the scuff on the car. Any refusal, I'm kind of still just because honestly, I want the best for my patient, but also I don't want that to come back and get me. So, like, with those refusals on your dizzy patient, what can you kind of guide your patient to do beyond when the ambulance leaves their driveway?
Yeah, I think these are patients. Again, your elderly patients are ones that you really have to take true care in when you're doing refusals on. Um, because the last thing you want to have happen is to walk in, you take their vitals, everything looks okay, and they say they don't want to go, and then you just leave. You don't necessarily try to cover any basis. You don't explain things to them. Not only is that bad from a protection standpoint for you, but arguably more important, it could be very bad for the patient, and I think that's why we're there. So for me, if I have a patient that's dizzy and they don't want to go to the hospital, one of my biggest concerns is them falling. Um, somebody who's dizzy and lightheaded. I'm sorry, my cat is hitting my curtain, so if you can hear that, I apologize. He is currently in his playing mode. Um, anyways, the issue with falling is really big, especially in the elderly population. They fall, they break a hip, they hit their head, they end up with a brain bleed, they break their wrist. Any number of things goes wrong, and I would encourage people at some point, if they really want to dive down into things, look up the mortality rate of people with hip fractures. It would probably
Oh, it's
shock
so
you.
sad.
So just really consider that when you're signing off these dizzy patients, like, are they a fall risk? And just really do your best to explain to them that, look, I know you're feeling okay right now. You did call for us. And if you want to not go to the hospital, that's okay. But these are the things I'm worried about. And these are why I think it's a good idea that you go and get checked out. And if you still don't want to go after explaining all of those things, then, I'm a big believer in patient autonomy. If they have medical decision capacity, and they look okay and they don't want to go, then by all means, that's their right to not go. But I would just really encourage you to cover your bases, really explain what the concerns could be and the risks associated with those concerns. And I know everybody wants to go back to the station. Everybody wants to relax and do whatever's next, catch up on those 10 charts that you're down. Um, but but really, it is important. These are patients' lives to consider, and the last thing you would want to do is have to go back to that apartment or house later and find them on the ground and they have a broken hip. That would be really unsettling, and I think it's worth taking the time to explain it to them.
That's a really good point about the falls. Again, you know so much more than me, and it shows. Um,
I don't know about that. I just think it's just a concern that I have is falls and injuries in these elderly patients, and of course that's the host of other things that could go wrong, from them having a massive cardiac event to them having a stroke or whatever have you. But falls in elderly patients are just something that I think I'm always going to be chronically concerned about, because it can be quite devastating.
and they do it all the time, so you never know if it's, you know, Miss Gertrude down the street. Is it, is this really just another lift assist, or are bad things happening? Um, so yeah, all encompassing. Dizzy patients. Um, I know on the way to these calls, it's kind of just that dread that, oh God, what is this going to be? Am I going to hear medical history all the way back from like 1961 to today? Or are we walking into something that's absolutely terrifying? But I would say, even with every call, you should always have that, it's the word premonition in the back of your mind of things, this could be bad. Even, I don't know. Dispatch is always either great or terrible. So I feel like that kind of plays into it too. But neither here nor there. Anything else you kind of want to leave with the listeners? Because I mean, we covered a lot, but I don't know. That's anything else you can think of. Anything else you want to add
You know,
in, throw in?
I guess my biggest takeaway that I hope people can get from this episode here is just have that index of suspicion for badness with dizziness. Don't necessarily just chalk this up to benign vertigo or a peripheral ear problem. Keep an open mind. Let the patient steer the conversation and really parse out whether, if this is a near syncope sensation where they feel lightheaded and they think they might pass out, versus true vertiginous symptoms where they're dizzy, their head is spinning, they're feeling motion or a sensation of motion. And then from there, just try to really risk stratify your patients. Is this an elderly patient? Is this somebody who lives alone? Do they have somebody who's going to be there with them? Do they have a history of heart disease? Are they on a lot of medications? Is their physical exam benign and reassuring, or am I seeing some stuff that's raising some red flags? And then go from there. If something is sticking out bad to you, I would much rather you always treat it as something is bad, and we can always de-escalate care from there, rather than missing a very serious pathology and maybe missing something important for the patient. So just have that index suspicion that this could be a serious pathology, and I think you won't miss it, and we'll go from there.
Absolutely. And with that risk stratification, um, I never want anyone, including myself, to be terrified of leaving a patient just because of the what could happen. Because you can hypothetical scenario overthink everything and after every call wonder, oh my God, did I do whatever? But definitely a good point. Just don't write it off just because it's not showing on the monitor. It's not showing right in front of you with every patient and in our older patient populations, I always feel like there's not necessarily more to the story that the patient's not telling you, but there's so many underlying things that could be going on. But Matt, Dr. Jim, if that's all you got, that's all I got, my guy.
Awesome. Yeah. Thank you so much for having me. It's always been a true pleasure, and hopefully we'll do another one again in the future.
Absolutely, especially now that you're done with medical school, you have what is it? Free time? What is
Yeah.
that?
Something like that, I guess. I don't know. I don't know about all the free time in the world, but every now and again I get a day off.
So, my friend, if that's all you got, that's all I got. And as I end every episode, so with that.
The 22 at the Lips podcast is designed to support, not replace, the relationship that exists between a practitioner and his or her medical director. The views and opinions expressed in this podcast are those of the host, guest, and not necessarily of Master Medics. The information provided during this podcast is intended for educational and informational purposes only. It is not a substitute for your approved protocols.